the Medicaid provision is limited but not invalidated. Roberts joins the left of the court. So it's upheld. It's constitutional.
I'm really glad we have that kind of news because this could have been a really depressing afternoon. So thank you for that. You always get the news right during your time to speak.
Well, I don't have anything to say about the recruiting to physicians, except I had mentioned in my presentation that we are looking at how to take RDAT out to other populations, to other groups. And I think one of the groups that we're interested in is how could a program like this be integrated into a major healthcare system? For example, Group Health Cooperative in Seattle, which is a group that we work with a lot in our research and clinical trials. So is there a way that a program like this can be made attractive, perhaps with a nurse delivery system, or just how can it be integrated into these larger systems so it becomes part of a program that's automatically referred to by the physicians in those centers?
One of the things that I think that we've heard here, and in my experience working with AOA's Alzheimer's disease program, is the ability to recruit people, enroll them, and retain participants in these types of programs is a challenge at times. So what are some strategies that you've found that have been helpful working with your particular programs in addressing each of these different areas?
Well, what we've seen with our recruitment, with our translation studies so far, is recruitment has been done in a number of different ways. There's been the approach where you have, for example, at a site, they have a designator recruiter. And so that might be a supervisor over who's overseeing the work by the particular trainers that are delivering the intervention. In other cases, the recruitment is done more by the trainers themselves. They're looking at their own caseloads, looking at the people who are being referred to them either in the Alzheimer's Association or in the AAAs, and seeing who might be an appropriate candidate for this particular kind of study or program. There's advantages and disadvantages to both of those. Having an individual who's specified as a recruiter, you have to have someone who's got the time and the funding to act in that capacity. But that kind of person also is more likely to kind of be going out and able to do the outreach, because if it's just being handled by the trainers or the case managers themselves, they've got their other cases that they're seeing in addition to implementing your program. Let me in doing outreach to groups like the Veterans Administration. And so I think some of the sources that I hadn't thought about before this conversation this morning, we've done outreach through talks to the association or to physicians and community conferences and those kinds of things. But I think there's definitely places that could be tapped that we haven't looked at yet.
I think I talked about this a little bit already, but generally speaking, I think that it's not hard to get people to participate in these programs once you have a population of people that's identified. When you're doing a study, it's a little bit of a barrier sometimes to get people to participate fully. Because people have lives and they've just been diagnosed with a major disease and they want to do other things. So if you're having a 10-week program, to get them to go to every session always is a little bit more of a struggle, I think. The struggle for recruitment is when you're starting something new in a community and you don't have a referral base. And I think I talked about what we were doing to overcome that. I think this meetup program, honestly, has been the most successful thing we have ever tried in terms of developing a pool of people in the community who are interconnected and groomed to sort of be folks who would participate in other things. It's a non-threatening way to engage people and then select who might be appropriate for other intervention.
I did my first study of the stigma of dementia in 1990, and I understand that this is a highly stigmatized disorder, and I do think we've tried to address that in our whole approach to our advertisement and how we talk about the program. If I put this is a program for early stage dementia on my brochure, I probably wouldn't have anybody knocking on our doors. So we have to be very careful about how we couch what we do and talk about healthy aging and memory improvement or memory sustaining. And I think just being aware of the stigmatizing effects of dementia has helped us in how we approach advertisement and recruitment. Our age range is 54 to 92. So I think also in recruitment, you have to think about who you're marketing to or who you potentially want in your program. And I do hope that we can meet the needs of young onset dementia. And so we think about that when we market or when we talk about what we do. And I think that's helpful.
One of the things that many of you have touched on is sustainability. Being able to be creative in terms of where you're looking for funding, being able to partner with different types of funders, and being able to generate data that shows that your intervention is not only effective in helping people, but also cost effective. So can you first say a little bit about any sort of data that you may have collected, analyzed, looking at cost effectiveness on what you found in your programs, and also any strategies that you've been able to use to secure additional funding or pursue additional funding, and then what the steps that you took to get to that point were.
Well, we have not ourselves at this point collected cost effectiveness data on RDAD. The larger programs in Ohio that are currently ongoing and are going to be coming to the end of their federal funding or their additional funding, will be looking at cost effectiveness issues as they move ahead in the next year or so in terms of continuing to implement the program. The new NIA-funded grant that Dr. Terry has to translate RDAD in AAAs in Washington and Oregon has as one of the specific aims, and has a co-investigator on the grant named to particularly look at issues of cost effectiveness. Some of kind of the things that I've observed over the years as we've talked to sites that are translating RDAD, and as well as some of our other interventions, are I think there's an issue of how good of a fit is this with other programs that are being offered within the agencies. Can RDAD be funded under dollars that are already available, for example, to a AAA as part of some other caregiver program support? Can you take staff who are already supported under one program and kind of add RDAD into it, or how much additional support do you need? That's an issue. It's also an issue in terms of cost effectiveness, I think, from the care receiver's point of view. I was thinking after I gave the mic away that another issue with recruitment has to do with, I think there can be an element of caregiver fatigue. That some of these caregivers, if you've got good caregiver support programs in an area and people have already been through several kinds of training programs, do they perceive what you have to offer with your new program as something that's going to be added benefit to them that's worth the time? And that's a kind of a cost effectiveness issue, I think, that isn't easy to tease apart, but that needs to be thought about. With RDAD, we're excited because it has this exercised component to it, which is unique from the more usual caregiver education and behavior management kinds of training programs that are found with other things. But still, I think that's something in cost we need to think about.
For me, this is a harder question. I think until we can embed some of this into healthcare, it's hard to analyze cost. I mean, you can ask people how much they are spending before and after, but how do you really get at real cost? We've done some of that work with care consultation as an intervention, but in terms of cost effectiveness data, I think that's a really difficult thing to ascertain if it's not embedded in a healthcare system. That's all I'll say.
We're so small that would sort of be out of our realm to collect that kind of data. I can say we're based, all of our structural costs are supported by the church where we're based. I can't believe that we're not extremely cost effective, considering we use a lot of volunteers. We have 2 paid staff and 5 volunteers every day. So that in itself, I think, speaks to cost effectiveness. As far as external support, when I need money for scholarships, I go to local foundations because they're invested in their community. And if I need $5,000, and I'm talking about very small money here, you're talking about millions, and I'm talking about $5,000 to keep a program going. I go to a local foundation, and we just got $5,000 from the Christie Foundation. It's a hospital. and because they understand what's happening in the community, and they're invested in the community. So I look at funding much differently than the other panelists look at funding, but it's helpful.
Can I just say, I think that's really important what you're saying, because we too are piecemealing a little bit here and a little bit there to get these programs going. We also, for Memory Club, people pay privately for that intervention or non-drug treatment, and I think that this it's very hard. We need more funding for this type of research on the ground, this type of applied research to look at these questions. There really, isn't a place to go to do this work for funding of this. So aside from small community foundations that are interested.
So I think braided funding sounds like it's something that's really important, that's been used to both develop and continue to deliver your intervention. Are you aware, or have you worked with any managed care organizations or other third-party potential reimbursers for your program? Are you aware of others that have? And what kinds of things have they done to initiate those relationships and hopefully pursue reimbursement?
We are in dialogue with Group Health Cooperative in Washington State about how a program like this could be integrated into their care. I'm not aware of anyone in Washington who has done this successfully, but I think if we look at models of something like the IMPACT program, where there has been other efforts through either a stepped care approach or where you can systematically implement non-pharmacological interventions for targeted programs with individuals who would benefit from them or who have not benefited from more mainline treatments that are being offered. I think there's a way that this could be done, but I haven't seen it done yet.
I don't need to say anything else. That's true.
Okay. Great. And finally, could you each give us some recommendations, we'll say your top 3, for what the federal government, states, and private sector can do to really promote the translation of research into practice in the community?
Well, I think something that's already happening at a federal and a state level is that organizations are getting the message that if we're going to deliver interventions for dementia care, if we're going to offer them, they should be evidence-based. And so what I see is increasingly the people who are providing care to families living with dementia out in the community really want to offer a program that has good evidence behind it. So I think that's an important first step to getting these translated out, is saying, if you're going to offer programs, they should be evidence-based. The question then becomes, how do you support those, particularly in this tight funding climate? It would be great if there was insurance coverage for some of these programs, and what it would take to have that implemented either at a federal level through a program like Medicare or Medicaid, or what it would take to get it into some of the larger healthcare providers or insurance providers. I don't know, but that certainly would go a long ways toward making the program sustainable if there could be monies that were coming from the care recipient side as well as just from the agency provider sides. Certainly if there were additional funds out there from federal or state groups to get grants to continue looking at effectiveness or translation work, that's great. But I think we need to somehow be thinking in a broader picture, more creatively, how we're going to approach funding, and on a big scale. I mean, you can put together a lot of money in $5,000 at a time, but that requires someone who's got a lot of energy and time to do that. And so